Okay. Good evening, everybody. So today I'll be discussing about a case of a post-burn contracture of the neck. So my patient is a 30-year-old woman who is a homemaker who presented with chief complaints of excessive scarring over the neck since the past 9 months and difficulty in extending the neck since the past 7 months. So the patient gives a history of difficulty in extension of the neck and excessive scarring since the past 7 months. So initially the patient had difficulty in extension of the neck followed by difficulty in neck flexion. She also has difficulty in climbing stairs following the difficulty in movements of her neck, and also she says that she has difficulty in looking sideways. There are no history of other contractures in the other parts of the body.
Your PPT is not visible.
Just 1 second, I'll just upload it again. I'll continue, madam. So no difficulty in mouth opening or in speech or any history of drooling of the saliva. So treatment history. So the patient was apparently all right 1 year back when she sustained accidental flame burns to her neck, abdomen, and both her upper limbs. So she gives history that she was cooking in the kitchen and she was trying to light a stove while her clothes caught fire. For an approximate time of 10 to 15 seconds, which was in a closed space, fire was doused with a cloth by her family member, and she was taken then to a nearby local hospital. So the patient was then admitted in the ward, and the treatment that she has received was IV fluids and alternated dressings for her wounds, and this was done for a period of 2 weeks, following which the patient was discharged and she continued dressings at her home, and after 3 months all the wounds have healed. All the other wounds other than the neck wounds healed within 2 weeks. She did not undergo any resurfacing procedures, no usage of splints, no physiotherapy received during her hospital stay, and did not follow up for assessment of her wounds. No previous surgeries in the past, no comorbidities, no habits, and no history of any allergy. My general physical examination slide, I just wanted to comment that she was conscious oriented with no pallor icterus, cyanosis, clubbing, or any lymphadenopathy. Her pulse rate was 80 beats per minute and blood pressure was 110 by 70 millimeters of mercury, and her height was 160 centimeters and her weight was 60 kgs with a BMI of 23.4. I would want to proceed with the local examination of the face and the neck. So in this diagram, 3 broad band contractures present over the neck, extending from the mentum to the sternal notch centrally, angle of the mandible to the right clavicle laterally, whole of the right clavicle laterally, angle of the mandible to the midpoint of the clavicle on the left side. Also, there is hypertrophic scarring seen over the right mandibular border with extension to the cheek superiorly by 3 centimeters, also extending onto the right infraclavicular fossa, the sternal region, and the right scapular region. There were also patchy areas noted of hypopigmentation over the right side of the neck, mastoid region, and the scapular region. So in this, in these images, it's visible regarding her contracture bands, the one on the right and the one on the left, and also the areas of hypopigmentation, as well as the areas of hypertrophic scarring that were also extending over to the cheek on the right side and also on the right scapular region. Also on Also, I wanted to comment on the scar. So the scar was blanching. It was slightly warm, non-tender, firm. It was firm in consistency with hypopigmentation. Range of movements of the neck. Extension was restricted to 20 degrees and mild ectropion of the right side of the lower lip was seen. However, there was no pull of the breast or the shoulder region. Mouth seal was good and speech was normal. I also examined donor sites such as the thighs, deltoid region, and as well as the chest. So other than the central sternal region, there were no scars over the chest as well as over the thighs and on the deltoid region. So I wanted, as we have seen in the apparent defect in this patient, I wanted to calculate the true defect. So I have calculated the dimensions vertically and horizontally by measuring.
Would you like to conclude with diagnosis and go for the investigation?
Yes, madam.
Krishnamurthy sir? Krishnamurthy sir?
I have muted myself. Sorry. I am available.
Sir, he has presented the history and examination. So, shall we ask him to proceed, or you would like to ask anything else, sir?
No, proceed. Proceed, please. Proceed.
Okay.
Okay. So my clinical diagnosis is postburn contracture of the neck, Osher grade 3 with diffuse hypertrophic scarring, which has an immature component with mild eversion of the right side of the lower lip. 1 second, my presentation is again. Sorry. With mild eversion of the right side of the lower lip. Investigations wise, I want to do an X-ray of the neck to know the position of the trachea, whether it is deviated laterally, just to know what are the difficulties that me and my anesthetist would anticipate in terms of intubation, and of course routine blood investigations for fitness for surgery, as well as to especially protein, total protein and albumin, and hemoglobin and coagulation parameters, and of course a COVID test in these times. So before proceeding with anything, I would want to first counsel the patient and discuss with the patient and her family regarding the timing of surgery, what is the treatment plan, the need for post-operative neck extension, possibility of nasogastric tube in her, the need for splinting, and long-term rehabilitation measures, and also consent for the same. I would also want to discuss the same with my anesthesiologist regarding intubation options, because we are looking at a difficult airway. So as this lady is having an immature scar at present, I would want to first give her pressure garments and a cervical collar with silicone sheets to first convert this into a mature scar, wait for a few months, uh, make sure that the patient is compliant with the treatment that I have given her, and then once the scar is more supple, I would want to proceed with my surgical plan. So my surgical plan would be an incisional release of the contracture bands and excision of the hypertrophic scars over the neck with skin grafting of medium thickness. So I would want to first, if intubation proceeds with oral intubation, endotracheal intubation, that would be the ideal scenario. However, we are looking at a difficult airway. So if that is not possible, then I would want to do a fiber optic intubation, or I would want my anesthesia team to proceed with the fiber optic intubation. And even if that is not possible, then I would want to give local anesthesia with adrenaline to the contracture bands and release it to achieve neck extension to such an extent that we can proceed with oral intubation, and then the formal release of the contracture bands and resurfacing with medium thickness skin graft. That would be my first choice of surgical management. Now, where I would want to place my incisional incision for the release, I would want to look at the point of maximum tension or stretch over the contracture bands. As in this figure, I have outlined the incision, and I would want to, the depth of the incision would be until I reach healthy tissues and incise all the scar tissue uh, up to the lateral points where I have mentioned, that is the neutral line or the anterior border of the trapezius here. And and also I would want to make sure that the incision is not linear, and I would want to fishtail the incision at the lateral aspects. So I have already assessed my true defect, which is 16 by 15 centimeters.
How you show the Meher? How did you assess the true defect you show?
Yes, ma'am. So I measured the scar from.
Slide you show.
Yes, ma'am. Yes, ma'am. Yes, ma'am. So the vertical dimension, I chose points, bony landmarks of the mentum and the sternal notch, and for the horizontal dimensions, I've used landmarks such as the acromion and the clavicle, and also the mastoid at the superior aspect. So the scar on which my patient had, so I have chosen a lady of similar age, build and height, roughly similar, and I have marked the points. I have marked the points from where the scar is present from these bony landmarks, and then calculated the distance. So in full extension. So so in this person, when I check the dimensions in full extension, the vertical length or the dimension was 16 centimeters, and horizontally it was 15 centimeters. So we are looking at approximate true defect of 16 by 15 centimeters. Shall I proceed, ma'am?
Okay.
So after I have released the contracture bands, and hopefully if no vital structures are exposed, then I would want to proceed with split medium thickness skin grafting. I would want to harvest it from the anterior and medial aspect of the thigh, and with medium thickness, and I would want to harvest 2 long sheets with very minimal fenestrations, and I would want to place it transversely, one from the mentum up to the cervicomental crease, and the other one from up to the sternal notch. And I would want to fix the grafts by a bolster dressing. I would want to use silk and make sure that I have a bolster dressing, and make sure that the threads are long on the transverse or on the horizontal aspect, such that the tie over would be corresponding to the junction of the 2 grafts. And another point that I wanted to mention was, as I am releasing my contracture, I would want to assess the extension of the neck. So I would want to place a shoulder bag underneath her shoulder, and also make sure that there are at least 2 head rings, so that as I'm releasing, I can remove one head ring and check if the extension is adequate or not. So so the endpoint of my release would be until adequate extension and lateral movements of the neck is possible. So once my release is done and I have resurfaced this lady with the grafts oriented transversely with minimal meshing, I would want to, and after a tie over dressing, I would want to put a POP cast immediately after the operation or after the dressing, and maintain neck extension post extubation by placing a pillow or a thick towel underneath the shoulder. And I would also want to place a Ryle's tube before she is extubated, because I would be expecting difficulty in feeding for the next 1 week to 10 days. And I would want to change my change the dressing for her on post-op day 5, and then once in 2 days. And after 2 weeks, after the grafts are taken up, I would want to change the POP cast to a thermoplastic splint or a hard cervical collar, and pressure garments to and ask her to comply with using the pressure garments for at least 22 to 23 hours a day for at least a period of 6 months, and then followed by giving her pressure garments at night. So this is how I would want to plan my management for this lady who's come with the postponed contracture of the neck.
Krishnamurthy, sir.
Yes, yes, please.
Sir, you can ask questions to him.
The basic difference, like this is a long case for anesthesia PGs. For us, the anesthesia problem is not the basic problem. Post-operative management, what kind of graft you have to take, what kind of fixation post-operative management. That is the more important points for plastic surgery. But anesthetist, he is trying to learn intubation technique, and you as a doctor, your principle is to do the best for the patient, which is reasonable, which is safe for the patient.
Yes, sir.
Anesthesia is a tricky business for these patients. I have lost patients during anesthetic procedures. So anything which is safe, That is what should be preferred. She is an adult. So would you still prefer fiber optic endoscopy over local? This is my question.
Sir, I would first prefer oral intubation itself, sir. Okay. If there is difficulty, only then fiber optic intubation would be needed, sir. That would.
Fiber optic is the next development. If you are going to talk about oral intubation, that oral intubation, if that is possible, we are going to do. What I'm saying is, in a contracture neck, oral intubation itself could produce enough problem. Some of the teeth may get knocked out, there will be bleeding, then the patient can aspirate. Won't you prefer local anesthesia over general anesthesia? Do you make this point? Okay.
Yes, sir, because the risks are way more in general anesthesia, whereas releasing contractures under local at least will prevent complications like aspiration and other anesthetic issues. So it is a safer approach, knowing all the risks that could happen. Right.
No, it is, the point which I am making is local anesthesia is safe. Local anesthesia is safer than ordinary intubation, oral intubation.
Okay, sir.
Fiber optic intubation is fine, where you have got an institution where there is no money as a problem, instruments available, more modern, it is possible. But a local anesthesia is more simple and straightforward. So when it is straightforward, will you use this or will you use a more complicated procedure? I'm sure anesthetist PG should also learn about intubation. But if it were our own people, what will you do? This is my point.
Yes, sir. Yes, sir. I would go for the safer option because yes, I understand.
Madam, you have something. Bhattacharya, you have something. You have switched off your microphone.
Yes. First of all, I thoroughly appreciated your presentation. Very nice.
Thank you.
And for the younger generation, I would like to say that after listening to Dr. Krishnamurthy's presentation, you must realize the importance of documentation when he shows long follow-up and rehabilitation of those patients who were looking horrible in the initial phase. So documentation is extremely important. I have few questions for you, doctor. Can I?
Yes, sir. Yes.
What is an intrinsic contracture and what is an extrinsic contracture?
Sir, intrinsic contracture is the contracture that occurs at the wound itself, compared to an extrinsic contracture where there is contracture of the surrounding tissues. So tissues that are surrounding the wound or the burns wound, which are having a contracture, that would be in because of the pull caused by the primary or the intrinsic contracture. So
what is the importance of this knowledge?
Sir, in extrinsic contractures, an incisional release is sufficient, whereas say in intrinsic contractures, the excisional release fares better, sir. So I think
I will just modify your statement. The extrinsic contracture correction indicates your adequate release of the intrinsic contracture.
Okay, sir.
Okay, that is a guide. Okay, for example, in this patient, the lower lip, right commissure is pulled, the nasolabial area is pulled. Okay, so yes, all sir. This will get corrected only when your intrinsic contracture has been adequately taken care of.
Yes, sir. Yes, sir.
Number two is regarding intubation. I agree with Dr. Krishnamurthy, but there is another way which we also often follow. Those who does not have, suppose, the fiber optic, then the anesthetist can use propofol or any short-acting anesthesia, and you be ready for the release. Just make a release as long as he is satisfied. and he intubates.
Okay,
So
sir.
that is another way. But I have serious problem with your incision, which you are showing on the. Is this incision is adequate? Are you going to incise and correct or excise and correct the contracture? Because there are hypertrophic scar, depigmented scar, and contracture, 3 elements. So
Yes,
if you
sir.
just release the contracture, subsequently the patient will require many more surgeries.
Yes, sir. Yes, sir. I understand.
So will incision and release is adequate for a selective area of neck?
No, sir. I would want to also excise the hypertrophic and the depigmented segments as well as
Therefore,
a whole unit.
your incision does not include all those, no?
Yes, sir. This incision was only for the release, sir. But I
Release.
agree. Yes, sir.
But your aim is not only release.
Yes, sir. It's not only release. It would be also
What,
to excise the hypertrophy.
what is the role of hydraulic dissection prior to excision of the scar?
So that would create a plane, sir, so that the tissues would be easier to excise
Yes.
away from the vital structures.
Yes. Therefore, the maintenance of hemostasis will be easier.
Yes, sir. Okay. Yes.
Okay. Now
Yes,
you talked about fishtailing. You said if need be, I will do fishtailing. Why fishtailing is done?
Sir, so fishtailing, I don't want my incision to be a linear one. So I also release the contractures to its entire extent on the lateral aspect. I would want to fishtail it. So that would again. So after fishtailing, the resultant draw area would be a triangular one. So I don't want it to be a linear one where it can again go in for.
Is fishtailing is a choice or it should be included in your method for adequate release?
Sir, it is a choice, sir.
That
It
means
is.
you will do only one fishtailing or two fishtailing. That should be enough.
Sir, it's more like as we cut and go, we need to decide whether it's adequate or not, sir.
So usually in such contracture, large number of fishtailings are required so that
yes,
it goes back to its place, normal place.
Yeah. Okay, sir. Yes.
Okay.
Yes, sir.
When you talked about the graft, you said medial side and anterior side of thigh will be your choice location from the thigh.
Yes, sir.
But there may be scar of the donor side of the graft itself.
Yes, sir.
So
I have
any person, especially in lady,
yes.
I would advise or expect you to say that I will take from the posterior aspect and lateral aspect so that the anterior and medial aspect are free.
Okay, sir. Okay. Yeah.
Okay, that will give long-term better result.
Okay, sir.
Then you talk POP. The table and the patient vomits.
Sir, I'm not able to hear you, sir.
If you give POP on the table after release and settling the graft,
yes, sir.
And if the patient goes to the ward and vomits, then she cannot be turned. She cannot move her neck. And she might aspirate.
Sir, I again lost you, sir. You said POP applied post-op and vomiting occurs in the ward.
Then the patient may aspirate.
Yes, sir. Yes.
So is it advisable to immediately give a POP or after the first dressing?
Yes, after the first dressing seems to be a more safer option so that there is no aspiration.
Yes. Because you are keeping a pillow under the neck, you are putting a POP, the neck is completely frozen. Patient is unable to move it.
Yes. Okay.
And why should you give a Ryle's tube? patient is allowed orally while she is sitting after operation on the evening. Why should you put a dry tube for 10 days?
Sir, I want to maintain the neck extension strictly, so I don't want her to aspirate.
It's just getting up during feeding and then continues with the position, and your neck collar is also there.
Yeah.
So additional problem of Royal's tube need not be there. That's the point I'm trying to emphasize.
Right.
What are the angles of neck? What do you want to achieve?
The cervicomental angle, sir, I would want to achieve an angle of anything between 95 to 120 degrees. So that is the most important one I would want to achieve at the neck region, sir. Mm-hmm. And extension and flexion of the neck, at least 40, the normal extension would be 45 degrees, 0 to 45 degrees of a range. Flexion and extension, and also lateral rotation of the neck. I would want to achieve that as well. So these are the angles and the movements of the neck that I want to restore.
When will you open your first dressing?
Sir, I would want to open it on post-op day 5, sir.
And if there is a hematoma from day 1 or 2?
Then I would want to change the dressing right away, sir.
No, I'm not asking that. If you are straightway opening on 5th day, and by that time there's a big hematoma for 5 days, graft is lifted, is it advisable?
Sir, I would inspect the dressing for any soakage. So if there is any soakage,
you have given a bulky dressing, you have given a POP. Where will you find the soakage?
Yes, sir. If there is any discharge or there's increase in the size of the dressing, then I would suspect it. But I agree with your point that if there's a POP, it could be masked.
So
then I would want to also the breathing could be difficult, sir, if there's a hematoma. So I would want to also look for her.
That will come after a long time. There won't be any breathing problem. Why should they?
So in that case, I would try to prevent this by achieving a good hemostasis before.
What else? What else?
Blood pressure should be.
No. You maintain hemostasis. What else will do on the table so that you are almost sure that your graft will stick to the bed?
I also want to make a few fenestrations so that there is no hematoma that is.
That is always done. Anything
also
else?
Also tie-over dressing, sir, a bolster dressing.
Before tie-over.
I would
Apart from tie-over dressing, what else you will do?
I think
methods to prevent separation of the graft from graft bed.
The examiner has answered already.
I want to secure the graft.
Use that word. I want that technical word from you.
Sorry. Yes. I want to secure the graft to the bed using.
Securing is not the word.
What are the methods?
Quilting sutures, whack dressing, tie-over dressing, bolster dressings.
So finally, you will incise and release or excise and release?
So for the intrinsic, I would want to do a complete.
This patient, you will incise and hypertrophic pigmented scar and the contract.
So I would want to excise and release, sir. I would want to excise the entire segment. So
you want to excise?
Yes, sir.
So will this incision is adequate?
I would say no, sir. I should have made sure that the incision covered an area where I could excise the entire contracture. So I would want to modify that.
Thank you. Thank you.
Okay. So when you plan the incisional release, I would like to know what factors you take into consideration. How do you assess if your incision is adequate?
I would first want to choose to incise at the maximal point of tension of the contracture band. After that, as I go deeper,
No, that point is correct. And how far later? How do you decide?
as long so at the after the incision, I would want to see where I hit the normal tissues. That is regarding the plane. Regarding the functionality, I would
No, no,
want to
no,
keep
no.
assessing the.
Mihir,
Yes,
one
ma'am.
is maximum tension accepted, and the second one you told you will cross. You have to cross the scar tissue.
Scar
Okay.
tissues. Yes, ma'am.
So your incision here, it is not crossing the entire scar tissue, isn't it?
Yes, ma'am. Yeah. Not the entire.
Okay?
Yeah.
Yeah. Always you have to go beyond the scar tissue and to the neutral lines.
Okay, ma'am. Yes.
Even the lateral side also here. There is a
Let's.
so you have to cross the inside the entire the scar tissue and go to the neutral line.
Okay, ma'am.
And there you will give your fishtailing at the ends of this at the neutral line. The fishtailing you will give, isn't it?
Yes, ma'am. Yes, ma'am.
So you can achieve the complete release when you incise the entire scar tissue in depth as well as laterally. Okay, if needed,
Yes.
to give back cuts
That's
if it
yes.
is incisional release superiorly and inferiorly also. Okay,
Okay, ma'am.
it is almost 360 degrees release you have to do if it is a incisional release is the plan for you.
Okay, ma'am.
Okay, so
Okay, ma'am.
after releasing, you told complete release, movements of the neck and the angle
Yes,
and
ma'am.
the contour of the neck you should achieve. Okay,
Yes, ma'am. Yes.
and what is the important precaution you have to take before resurfacing?
Uh, I should make sure that scar is supple. It's a mature scar,
Yeah,
uh,
that
and vital structures are not exposed, and entire scar is excised, and I don't leave behind any contractures, and excision of the hypertrophic scarring as well, not just the bands.
the perfect hemostasis is the
Perfect.
one which you have
Yes.
to achieve before going for
Yes, sir.
resurfacing. Okay,
Yes, ma'am. Yes, ma'am.
so
Yeah.
that is one important point. And you said you will give conservative method of treatment for this patient until the scar becomes supple and fit for the release. Okay, so if she wants the release at this stage itself, will you accept? And what are the problems you come across if you release this type of at this stage?
Yeah, so the more propensity for recontracture and hypertrophic scarring again, madam, if released when the scar is immature and resurfaced with grafting. However, if it was a smaller area and she wanted it now, then a flap would have been an option. Uh, but I would have reassured her and explained to her that the uh, the advantages are less and the disadvantages would be more if she chose to get it operated now as compared to a few months later. And I would want to tell her that it would give some time to her to get used to pressure garments and splintage, which she would anyway need after a surgery. So I would want
So
to
that is one problem you will recurrence of the contracture, and on table there will be excess bleeding. Okay.
Yes, ma'am.
Yes, and if there is a continuous ooze bleeding, even in spite of attending the hemostasis, the graft take up also you cannot give 100% assurance. So the one is bleeding, another is graft loss, and a third is the contracture recurs due to the bed contracture, right?
Yes, ma'am. Yes. Yeah. Okay.
And what is the aftercare of the graft you give for this patient? You have done the primary dressing, secondary dressing. The graft take-up is good.
So as
So
the skin grafts are devoid of sweat glands, I would want to give a mild moisturizing agent. So just a bit of coconut oil is sufficient and easily available in our setup. I mean, and affordable for our patients as well. And scar massage uh,
yes.
and pressure garments following that.
And splint. How long
And
you give the splint?
splintage should be there at least for a year, ma'am. Minimum of 6 months, but it has to go on for a year. So I would
Yes.
advise it for at least a year.
Yeah. Okay. So if the patient is having associated PBC axilla also, can you go ahead releasing both the contractures? Will you
No,
advise, or
no,
what is the reason?
no, madam. It's difficult to maintain position if we release both the contractures. I would give preference to the neck first, and then release the upper limb contractures. Uh, so that would be my uh, modality or order of management of these contractures.
Yes. So the splinting will not be possible, full splinting in the extension if you do both at a time. So it has to be staged in a different
Yes,
times.
yes,
First is the neck. Yes.
yes, yes, ma'am.
Dr. Mihir, can I just ask you a few questions?
Yes, sir. Yes, sir.
Very nicely you have presented. A couple of things I just want to ask you is you talked about the cervicomental angle, that is very important, right? My question to you is, what do you do to actually maintain the cervicomental angle? How do you actually, what are the measures that you would take to see that the cervicomental angle is well formed?
Making sure that 2 long sheets of grafts are harvested and oriented in a transverse direction, and the junction where the 2 grafts meet. So at that point, I would also want my tire dressing to reinforce that. So this is achievable mainly with grafts compared to a flap. So I would always choose to use grafts to resurface PBC of the neck, mainly for this reason, as well as it gives better contour to the neck. So this is how I would want my cervicomental angle defined by the threads that I use to secure the grafts.
And then any other surgical technique you use to actually get well defined? The other way of doing it is, you can actually, in addition to leaving your sutures, that's in the cervicomental angle, the quilting stitches that you take in the cervicomental angle, what you do is leave both the threads very long, so that one could be used for the cervical part and the other could be used for the mental part. So that is one way being sure that that angle is well formed. Second thing is that once you start releasing it, in few patients, especially in slightly obese patients, you would probably have to do some bit of excisions, or you can even do the tightening of your muscles, the subcutaneous muscles, the platysma. You tighten it so that you get again a relatively better looking.
Okay.
So that is again another thing that we actually.
Sometimes
we'll have to do a small bit of excision also of the fat to get a much better appearance. And then all your quilting, all your fenestrations that you make on your grafts, you make it parallel to this particular cervicomental angle.
Yes, sir. Okay.
Another important thing that I wish to tell you, already I think it is already covered by you also. This sir was telling, Bhattacharya sir was telling, the most important thing is that we should have a perfect hemostasis. So that is a very important thing. So again, when we are actually going, especially when we are releasing this, if you use too much of Tumescent solution or not, post-operative, probably an hour after you give your Tumescent solution, then there could be reactive bleeding. So that is again something that can happen. So as far as possible, minimum amount of Tumescent solution should be used, and you have to make sure that all your hemostasis is perfect, and make sure that there is no bleeding. And then before you do your tie over, you have to actually, through the small fenestrations, you have to use a small syringe with saline, and then clean it up again to make sure that there is no clots under your skin. Okay. So that also you can do, and then you do your tie over dressings. So I think that is all. I think I just have a couple of questions in the chat box is there. If Krishnamurthy sir can actually answer them, it will be nice. Sir, Jaswant has asked one question, sir. Sir, where exactly has to be the fishtail incision placed? Is it in the contracture or the normal skin junction, or is it in the scar tissue itself?
Fishtails make
yes,
fishtail makes a linear incision into 2 dimensions, and sometimes into a 3-dimensional defect. So fishtails are important, and when you are making a fishtailing, it should be the normal tissue, because the normal tissue you will find that it has acted as a contracture has developed. That particular portion of the skin which is beyond the contracture has stretched, and so it would have acted something like an expander, and so you will have enough skin in the normal tissue, and you will be able to convert into a very good defect. And without a fishtailing, the way you are releasing will not be adequate. Fishtail is always a must.
So another question, sir. In this particular picture, you can see on the left-hand side of this neck, there is a small area, probably 2 into 3 centimeter, one island of normal tissue is there. Would you actually retain that tissue there, or would you excise that tissue and then cover the whole thing with one sheet of graft?
In this given patient, you find that the donor area available is plenty, and the neck is going to be exposed for a cosmetic reasons. So it is better to excise that small island. You feel unhappy that you are removing something which is normally there, but cosmetically you will be able to achieve a very good result by making it symmetrical. So you go mastoid to mastoid, or the ear as a point, connect both this one single line, fishtail on both sides, remove that small island. Then you will be able to get one 2-dimensional defect, and the sheets of skin graft will fit in well, so that ultimate cosmetic result will be far better. Releasing half of the neck will not give you that kind of a result. It will be patchy, and the patient will continue to cover the neck. She will not be happy with half release. This island we will have to sacrifice.
Yes. So, and what about that maybe a centimeter or so posterior to the second scar, that after the island there is a hypertrophy scar is there. would you actually excise some normal tissue posterior to that area also, so that or you just end it at that particular scar?
You may have to exercise a little bit. Ultimately, on the table, if you can rotate the head to the right, to the left comfortably, stretch the head anteriorly and posteriorly freely, and everything has been released to your satisfaction. You may have to exercise a little bit to get a uniformity. In this particular patient, donor area is not a problem. Intermediate thickness graft is not a problem. You should be able to put more graft in the first sitting. The patient may not turn up for the second sitting of improving her face. So you do as much good job in the first stage. The fishtailing, as what our Dr. Mihir has done, is not enough on the right side. It has to be more. It has to cross the scarred area and it has to be more. As Dr. Bhattacharya pointed out, one fishtail may not be enough. You may have to do 2, 3 in that fishtail itself.
So in this particular case on the right hand side, once we excise this particular hypertrophic scar, you would notice that I think at least 2 centimeters of the mandibular area is going to require some sort of a graft. Would you actually do some fixation of the pulling down the cheek skin towards the angle of the mandible and fix it or something to avoid visible skin graft on the cheek, on the chin, sir?
If you would have followed this patient from day one and as the wound has been contracting, you would have noticed that about 40 days before, this patient's contracture would have been less and the facial skin would have been elsewhere. What has happened is, as a contraction develops, it is acting like a tissue expander. The skin has been stretched. When you release it, the skin goes back to normalcy and there will be sufficient skin available. I don't find it is required to anchor the skin in various other places. Actually, what I was taught in my younger days is you make it a bucket handle. That is, when you make this incision, there will be 2 flaps and put the graft underneath on the raw surface of those small edges so that you are able to add more skin. But excising the scar gives you fairly good result and the stretched skin goes back to normalcy. I don't find there is any reason for you to anchor all this in various other. Your graft take should be 100%. You should aim towards a graft take of 100% rather than anything else. That means absolute hemostasis and putting a good graft, small holes. I don't use a fenestration because that produces a scar. I use 18 gauge needle or 16 gauge needle, make holes. They leave a better scar than fenestrations. Fenestration often leave dots and marks.
Thank you, sir. Sir, Dr. Sudesh, you had raised your hand. Do you have a question? Yeah, I think this question would have been answered. Sir, you wanted to do a small presentation, sir. Is your presentation ready, sir?
Can I request?
Yeah, sure.
Kindly switch off. I will open my tray.
Mihir, you can actually stop sharing your screen.
Oh, okay, sir. Okay.
Yeah, thank you, Mihir. It was very nice. You had actually covered it very extensively. Thank you very much.
Thank you, sir.